Is it live now, I think?
No, Ashok will give us the warning.
Yeah, we are live now.
Just a minute.
Make a black and white combo for 4th of August.
Today there's that online meeting also, 4th August.
Going, starting at 7:30.
But that'll go on, I think. Or something. No.
We have a parallel meet at 9.
Acha, Z batch.
All set, Ashok?
Okay, we are live. We can go ahead.
Thank you very much, Ashok, for your sterling work in orthopedic education. I welcome you all for our 3rd webinar, along with my co-convener, Dr. Surendra Patil. These webinars, I hope, will give clarity to the concepts which are emphasized by the eminent faculty and will help in day-to-day clinical use for the participating surgeons. After discussing planning and templating, which is, like we said, a mental surgery, we looked at the acetabular side and we learned the art and science behind the cups and the tips and rationale to select them, including the need for some basic key instruments like the long Hohmann retractors and various curettes. And hopefully we learned the tips to make the technique reproducible. In this webinar, we are going to look at the art and science of stems in hip replacement, and it's really a great pleasure and privilege to have a lecture by Mr. Jason Webb from Bristol, UK on cemented stems. And for this, I'd like to thank Dr. Mahesh Kulkarni for this effort in getting Mr. Jason to talk with us. We also have Dr. Vikas Kulshrestha from the Indian Air Force, who is a great ambassador from the Armed Forces Orthopedic Surgery, and he will cover uncemented stems. And we have our eminent panelists with us, Dr. Nikhil Shah from Wrightington, Dr. Mahesh Kulkarni from Pune, mainly at Dinanath Mangeshkar, Dr. Narinder Kumar from Medanta, Lucknow, and Dr. Surendra Patil and myself. We will round off the talks with various aspects pertaining to stems, and without further ado, I will hand over to Dr. Vikas, who will run the presentation, which Jason kindly recorded for us because he could not be here today due to his work commitments. So over to you, Dr. Vikas.
I'll just share my screen. Dr. Jason's presentation is right here. This is on cemented stems.
Right, thank you very much. My name is Jason Webb, and I'm a consultant hip surgeon in the Avian Orthopaedic Centre in Bristol in the UK. And I've been asked to give a talk on cemented total hip arthroplasty with reference to the cemented stem. I'd like to thank Kieran for and all the team involved with facilitating that for me, and particularly to my friend Mahesh Kulkarni, who asked me to do this last week. So here goes. I'm afraid, owing to work commitments, I won't be able to give the talk live at the time of your presentation on Tuesday. So I'm recording it now, and the team have said that they will play it for you at the time. These are my disclosures, and here we go. The outline for this talk will be to advise on why one should be using cemented stems in one's hip replacement practice. So the evidence behind it, then to look at the fundamental basic science of cement, because if you don't understand that, you won't use cement well, and you won't do cemented hip arthroplasty well. And all joint arthroplasty's success comes down to an understanding of the interfaces, and that's particularly relevant in understanding why cemented stems are successful. So we'll talk about interfaces. That then links in with the particular stem designs that have worked and those that haven't. And finally, a brief bit on technique. You can't learn how to do a certain surgical technique in a talk. You have to experience it. You have to experience it. So in courses to begin with, and then during your training, being supervised by your trainers. So to start off, why should we use it? Well, you just need to look at any registry. You can look at old registries, such as those from Scandinavia, the largest of which is the Swedish Arthroplasty Registry, and you can see that cemented implants perform better than the overall performance as regards longevity, but particularly when compared with uncemented implants. So that's the not the old teaching, but that's the traditional evidence for their use. And then if you move to the largest registry and the most modern largest registry in the world, the UK National Joint Registry, you get up-to-date information that still supports and in fact really reinforces that message. So there was a time when cemented use was going down, but that has changed. And the trend, if you look at the graphs here of the usage, if you combine fully cemented with hybrid cemented, i.e. a cemented stem, you can see that those outnumber the uncemented stems in the UK registry. Uncemented is going, fully uncemented is going down in popularity. So fully uncemented is still very prevalent. Of the million cases of the million hip replacements in the registry now, we've got about 400,000 are fully uncemented, 350,000 fully cemented, but with another 227,000 as hybrid. So that being the most prevalent means of fixation is a cemented stem. And why should you use it? Well, the evidence is there. If we look at our 15-year revision rates from the National Joint Registry, we see that the best results are for fully cemented at 5.46%, followed by hybrid, i.e. it seems to be that the cemented stem is protective. And that's with the registry showing the most common forms, the most common indications for revision as you would see in any mature practice, with aseptic loosening being the greatest, then a mixture of instability and infection at roughly about 12 to 13%, and then an increasing workload of periprosthetic fractures as our population becomes more elderly. And then if we divide that down even further for the purpose of this talk and look at the most popular reconstructive couplings within the National Joint Registry, we see as follows. So for fully cemented, the most popular in the UK is the Exeter with the Elite Plus OG Cup. And that revision rate at 13 years is only 2.89. Okay, so even better than those amalgamated results we just saw. The most popular hybrid is the Exeter Trident, and still very robust figures, 3.38 at 13 years of a revision rate. The most popular uncemented coupling is the Cori Pinnacle, and even when you have removed the metal on metal influence, you can still see that the revision rate is double at least those for the cemented and the hybrid at 13 years. So the evidence is very strong. The argument would be, why wouldn't you use a cemented fixation, and in particular on the stem side? So let's move back and understand the background as regards polymethyl methacrylate or bone cement in its own right. It is an old biomaterial, first formulated in the mid-19th century and known as acid acrylic, i.e. this very strong smelling resin. It is an acrylic, and different versions of it with a sort of slightly higher molecular weight are prevalent within industry as plexiglass or perspex, depending on where you are in the world. As I said, it rapidly became used within medicine, initially for filling in defects within the skull, but then popular within dentistry and the use in replacement teeth and dentures. And then it started to become used in hip implants, but it wasn't until its use was popularized by Charnley when he invented modern hip replacement that it really grew in usage and has continued ever since, and in particular is popular in Western Europe, Scandinavia, and the UK. It is used elsewhere widely around the world for many reasons, but that's where it's particularly popular in the use in hip arthroplasty. And Charnley, who was a genius and who meticulously tested every aspect of his joint replacements to allow them to become such a success, denoted, the operation of the 20th century, liked bone cement. He liked it because he used it as a load transferring device to optimize the bone biomaterial interface. And we'll come to understand the importance of that. And the reason he liked it is it significantly increased the surface area of that interface. But to get the success in the clinical usage, you have to understand the chemistry of polymethyl methacrylate. Now, the amazing thing, and the reason we can use it in theatre, is it is a polymerization reaction that occurs at room temperature. Heating occurs during it, as any polymerization reaction, but you don't need to heat it to get that working. Variety of molecular weights depending on your formulation, a variety of ways to sterilize it. The best are usually ones that don't disrupt the chain molecule structure, and that's why ethylene oxide is more expensive, but it's better. And the addition of copolymers is what has changed, that has made cements different to each other. The most successful worldwide are the Palakos cements, and they use a methyl methacrylate copolymer. So are all bone cements the same? No, they're not. And it's because they vary by their constituents, their composition, and particularly by those copolymers. Particularly in the powder is where the differences are present, and it's things such as the X-ray contrast, whether it's zirconium or barium, or whether there are antibiotics in there, or colorants to help distinguish it from the bone. And if, such as in my research for my MD, you look at it on a molecular level, you can get scanning EM images to show you your polymers, which is, as you see there, you've got a crystal of gentamicin antibiotic there up towards the left, and the radiopacifier zirconium oxide there as well. So it's fascinating on a chemical level, and it's those differing constituents that vary the behavior of this useful biomaterial. And so one thing that's interesting is the modulus of elasticity, the stiffness of it. And as you go more hydrophilic, then you become more flexible. And so it's the methyl methacrylate copolymers that make it more hydrophilic and increase its elasticity, as we'll see in a minute. So those chemical aspects are key to then denoting the mechanical properties. Remember, all of these things, as usual, come about largely by chance, but where then people recognize the differences and then can extrapolate and utilize them is where these things become so useful in medical practice. So if you as a surgeon, the things you're interested in are what we call the working properties. You want to know that when it's handed to you by your scrub nurse, that it's gone through its dowing time, you can work with it, you've got plenty of working time so you can get your implants in before it goes off. But you also don't want it so sticky on your gloves that you can't work with it. Next, you want to know that it's reliable. It's got reliable static properties that mean it's strong enough. It's able to put up with the mechanical forces that will be sustained in day-to-day activity. And those are all covered in numerous guidelines. But the one for the UK and Europe, etc., is the ISO 5833. So you can't have a cement that doesn't pass those, and we'll see those in a minute. But the thing that has made it a success in orthopedic surgery and hip replacements are the viscoelastic properties. And my MD was partly looking at those because they're not covered in any of the guidelines and the requirements. And when they have been got wrong, there have been some real disasters in orthopedics, as I'll go on to demonstrate. So these are the requirements from ISO 5833 for a cement to be marketed. And so obviously any that you use are stronger than these and flexible, such as these. And as with everything on this planet, most things are stronger in compression than they are in tension or in shear. And that's just the same for bone cement itself. But it's a fascinating material because it's a viscoelastic polymer. So although a solid, it demonstrates some more liquid type behavior at various temperatures. And once it gets those changes in its behavior and demonstrates their viscoelastic properties, then we can understand and utilize those because they are creep and stress relaxation, which are helpful. Now, the other reason why it is helpful is because of its relative properties in the context of total hip replacement, and that's because it is flexible. It's got a Young's modulus of 2 gigapascals, which means it's less stiff than the cortical bone into which you'll be placing it. It's significantly less stiff than the metal stem that will be sitting in it, but it's more stiff than the cancellous bone. So it acts as a fantastic elastic buffer between those relatively flexible and stiff elements of a total joint replacement. Now, the thing that's important about its viscoelastic properties are these properties of resins, of acrylics, called glass transition temperatures. These are where a material that is a solid softens slightly and becomes more liquid in its behavior, making it less brittle, such that cement is less brittle in vivo than it is when we test it in the laboratory. And it's the heating within the body that achieves that. The other thing that's important is that anything we implant in the body is surrounded by water because of the tissue fluid. And that has a plasticizing effect. And the cements that are better at this are those that are more hydrophilic, i.e. their copolymers, such as you get in the Palicus cements, draw liquid towards them because the liquid is absorbed into the mass of the cement and it lowers the glass transition temperature by approximately 20 degrees. So if we see something like Palicus or Simplex down there at the bottom of this page would in the laboratory in vitro have a glass transition temperature of 85 to 95, the plasticizing effect in the body is that you would drop that by 20 degrees. And there are usually a variety of glass transition temperatures where the resin goes through stepwise changes to be more liquid in its behavior. So that changes it and makes it better able to undergo viscoelastic changes such as creep. And has this ever been got terribly wrong? Well, it has indeed, because there was a cement called Bone Lock. People erroneously were concerned that bone cement, when used in joint replacement, would kill the surrounding bone cells because of the exothermic reaction. Now, it doesn't happen for a variety of reasons. The heat is taken away by the blood supply and also by the implants that you put into them. But anyway, they thought it was a problem and they developed this low exotherm cement. But unfortunately, it had incredibly high viscoelastic properties because it had such a low temperature that its glass transition temperature was 58 in vitro, and therefore it was body temperature in the body, and that meant it crept away. And Bone Lock had dramatic 40% failure rates at 2 years and had to be removed. So the viscoelastic properties, as I said, are key. They are what the right type of femoral stem design, it's what allows them to be successful. And we'll go on to that in the next section. But it also is something that you should be aware of when you are doing the surgery. So, for example, that very common thing that we will find is that the cement's going off a bit quicker than you were expecting. Maybe it's a hot day or something, and your stem is only halfway in. So what do? Do you hit it to try and get it in? Well, you know that you shouldn't, because cement is a viscoelastic material, and therefore the higher the rate you load it at, the stiffer it becomes. So you don't hit it with a mallet to try and get it to go in. You just keep steady, slow pressure. But if that really doesn't look like it's going to work, get it out and clear everything out and start again rather than trying to hit it. Okay, so and finally on the viscoelastic properties, it's this behavior. You've got these bonds, these non-covalent bonds between your polymer chains. You've got these long chains of your methyl methacrylate, and you've got these non-covalent bonds, and it's the glass transition temperature that lets those bonds weaken and lets the sheets of the polymer of the methyl methacrylate slide against each other. And because that happens within the body of the cement mantle, it doesn't fail. The movement is happening between those bonds rather than at the interfaces. And that's what we'll talk about now. The reason Charnley decided the best way to fix his implants within the body with cement was he gave a 65-fold greater interface area than with the uncemented implants he was trying to develop at the time. So let's look at those three concepts. First of all, uncemented. This is working as a bone stem composite beam. You fix it in the body where it jams in the bone, but then any of the loading forces, once you start going, are being taken as shear forces at the bone implant interface. And so there's high shear, and we know that any interface, any material likes shear less than compression. Now we're going to look at the two types of cemented. The first is similar in essence to the uncemented. It is the cemented composite beam. Here you've got a rough stem within a cement mantle, usually fixed there with a collar. Here again, because of the very strong bond between the stem and the cement mantle, all of the loading forces are then transmitted to the bone cement interface. And again, we're getting high shear forces. And once the stem debonds from the cement it's sitting in, then you have two different interfaces wearing out with high shear and causing a lot of wear debris, as we'll see in a minute. But the one that worked by accident, but then was realized why, and then has been developed so successfully by many companies, is the taper slip, or the forced closed design. Here you have to have a polished, tapered stem with no collar. It's got to sit within your cement mantle, but because it can then subside, one, because of the creep of the cement, the viscoelastic properties, but also because you leave a little void at the tip of the stem so that it can slip by a millimeter or two over the first year or so. As it does so, it converts shear forces into compressive forces, which are good for the bone and are good for the interface, such that you're not causing a breakdown of your interface. Because once you lose your interface in whatever implant you've put in, your implant has failed, it's loose. So this bone cement interface has ensured the great longevity that we see in the registry figures, and it relies on both macro and micro interlock, and those rely on how well you prepare the bone with lavage and pressurization, as we'll go on. So the cement in this scenario is offering you that micro interlock. You are forcing it into the cancellous bone. That gives you immediate stability of the implant so they can be up and about on them day zero. Other benefits, there can be antibiotics in it that will deliver high doses exactly where you need them to reduce your risk of infection. It distributes the load, so it loads the bone and doesn't lead to stress shielding, and it gives great long-term results. And this is what you're looking at. These sections, you can see how the bone cement has permeated out into the cancellous structure. And it's favorable to your interfaces because it produces compression and minimizes shear and tension. Remember, shear is the main failure mechanism for interfaces in hip replacement. And the Exeter group, with their early work, showed that the optimal thickness of your bone, cancellous bone, should be about 2 to 3 millimeters. And when they had all their various modifications of the parameters of optimizing their fixation, they showed that 2 to 3 millimeters was 100% stronger load at failure than a bigger amount of cancellous bone left at 5 mils. If you clean the surface, significantly better. If you put your cement in and your stem at the right stage when the bone cement is still got a low enough viscosity to pass out, better than if you're leaving it later on. If you pressurize it, again, much better. And if you do all of these things well, you can have an 800% higher load at failure compared to a technique that doesn't do any of those. And that's Clive Lee, one of the co-inventors of the Exeter Stems research. More research on that, looking that, if you just leave the bone as it is when you cut it, that gives you that interface strength. If you brush it, that's improved. But if you do pressurized lavage, really clean it out, it's significantly 16 times better interface. So that's what it looks like when you cut the bone. But if you wash it, you get this much better honeycomb that will be of cancellous bone that will allow the bone cement to be forced out into it. And on scanning EM, you can see where the bone cement has actually gone out into the bone itself. So we know how bone cement works. We know how the interfaces work. So how is stem design, which ties in with what we've already discussed, utilize that? And we've seen for cemented stems, there are two options. There's the composite beam and the polished taper. So Charnley's initial stem, the flat back, was a single taper. But it then went on to the round back, which was a matte stem, and then its various iterations and how then things evolved and other companies copied it, went into what we call a composite beam, because there was a collar and you had a rough stem. Exeter came up with a stem that could go in through a posterior approach, and although they had a time where they had a matte coated one, they realized the results were poor and found that it was because they had changed from polished to matte. And when they went back to polished and looked at the science, and Clive Lee was key to that, then they realized why it was successful. And many imitators have since come with variations on a theme. So a composite beam forms a composite beam with a femur, just like an uncemented stem does. It's a shape closed design. The collar makes it sit there. And remember, the Charnley stem is the reference for mean surface roughness. It's got a RAR value of 1. It's usually collared, and the stem the stem cement interface is stronger than the bone cement interface, and those shear stresses are all transmitted, and they fail, as demonstrated largely by the American literature that use mostly composite beams. So this is what it looks like. And the problem is it lasts for as long as the bond between the stem and the cement lasts. But those bonds always break down. They always debond. And when it does, you're then getting wear at that interface as well as the bone cement interface. Debonding will always occur, and then failure comes, and you get this. So we're not even getting polyethylene wear debris. We're actually getting the wear debris and the failure at the interfaces of the bone cement itself. And then that opens up an even larger potential joint space for any polyethylene wear debris to get. We get massive osteolysis, bone loss, and a painful loose joint. What about the taper slip? A forced closed design, collarless, polished taper. It subsides within the cement mantle because you leave a little void at the end, and the cement can creep because it's a viscoelastic material. It's steady and ready to go on day 1 or day 0, but over time it gets even better because it loads the bone in compression, so the bone stays there by Wolff's law, and the stem becomes better fixed over time rather than less well so. So it's favorable. Here we are dealing with smooth, maybe 1/100th of the mean surface roughness of something like the Charnley stem. Shear stress is much lower, and therefore better compressive stress is there. So this is the design that has been proven in all the registries to be successful. And if you look at Exeter's results themselves, overall survivorship at 33 years for their stem at 85%. And for revisions for aseptic loosening, there's a survival of 93% at 33 years. So superb results. Basically, you put one in on your first day as a consultant, and it's not going to be revised again. You don't need to worry about that stem again during your career, unless something unfortunate happens like infection or something like that. But for aseptic loosening, the most common reason why we have to revise implants, you don't need to worry about it. And if you look at groups, not the inventors, but you look at groups such as in Bristol who were using different stems, again, excellent, robust results in long-term results. A very quick aside, what about cement and the use of antibiotics? Well, it was Buchholz at the Ender Clinic who developed the idea of putting antibiotics in, and we use them both in two means. One, to prevent you getting infection with your primary joint replacements, and secondly, higher doses in helping with our treatment of prosthetic joint infection. Now, that's a subject for another talk. In fact, I gave one for Mahesh's team recently. Your ideal antibiotic has to be a good antibacterial spectrum. It's got to kill the bacteria. It's got to have low initial resistance and resistance development. You don't want it to be highly sensitizing as regards allergy. It's got to be very water soluble, and it's got to be thermally and chemically stable. And an additional one that has lasted all these years that still works well is gentamicin, because it covers all of those bases. But are we now moving into an era where we might need to be using dual antibiotic cements? Well, it looks like the results are probably yes. The registry data suggested that. We had a paper a couple of years ago that's showing that probably single antibiotic cements are no longer as effective as dual antibiotic. And this pilot study for what is now a multi-center randomized controlled trial in the UK looking at dual antibiotic compared to single antibiotic cements for patients undergoing hip fracture fixation, hemiarthroplasties, showed a significantly lower infection rate when you use dual antibiotic cements. So antibiotic additions to the cement is another one of its useful characteristics. Right, finally, let's talk about the technique. What about the technique for hip replacement cemented stems? As I say, you can't learn this from a talk. You can get the ideas, but then you want to go and be taught by a center or by a trainer who is experienced at doing it, because you do need to develop experience in whatever surgical technique you're going to use. And but you've got to understand then what are the right implants to use. Broadly, I know you've had a talk last week about the acetabulum, but broadly, we use a posterior approach, as most dedicated joint replacement surgeons do in the UK. On the acetabulum, you need keyholes, pulse lavage, cement pressurization, a flange cup design, and that allows you to get accurate alignment. In the femur, go in via the true axis of the proximal femur, the piriformis fossa. You leave 2 to 3 millimeters of cancellous bone. We've seen why that is. You wash the bone effectively, you pressurize the cement, and you put in a polished tapered stem. And then you repair everything at the end, and hopefully that one is going to outlast your consultant career. In a little bit more detail as regards the technique for the femur, you get your entry point, as we said, piriformis fossa. You put in a tapered reamer, making sure you are out lateral enough with your box chisel so that you're going straight down. Never commit varus. The main problem is, even though cemented polished tapered stems are very forgiving, if you're in varus, then you're not going to be getting the right size stem in that you templated and planned, because it's getting stuck. So get out lateral, go straight down. Then you use your rasp and broaches, get to the good amount of cancellous bone that the broaching system should use. I always do some carretting into the greater trochanter and lesser trochanter, so you've got your macro interlock as well as the micro interlock, which is the interlock you get within the cancellous interstices. Then you put your trial in, check it all works, fine. Right, next thing, you're going to want about a 2 to 3 millimeter cement mantle. You put your distal cement restrictor in, you wash thoroughly, pulse lavage, dry it, centralizes on your stem. Then the cementing is what I describe to my trainees as icing on the cake. Imagine your cement gun, icing, the cement goes down, and then your spout is above this layer of cement that you insert. Put the stem down, maintain the pressure until it sets. Whilst it's setting, I do lots of washing so that there's more means of reducing your risk of prosthetic joint infection. So the top image there is what your canal will look like before you've sucked it out, but you've given it a good wash. And there in the acetabulum is that combination of macro interlock, the draw holes, and the micro interlock, which are the cancellous spaces. Now, people often talk about cementing generations. These are American-generated terms, so they're not so relevant. So the first generation was basically mixing it in a bowl and poking it down with your finger. Then between the 70s and 80s, they described second generation. So it was still hand mixing, and it was low viscosity cement, but you put it in with a syringe. Third generation, again, we're a long time ago, 80s, mid-80s. This time, vacuum mixing, proper vacuum cement guns, pulse lavage and cement centralizers and cement spacers. And then people talk about fourth generation, etc. But those are all slightly bogus terms. So what I would describe that you should use in your operation notes is to say that you are using modern cementing technique when you've done all of those things that we've described in that I've described in the technique just above. Vacuum mixing is important because it produces a much more homogeneous cement mix, which is less likely to have mechanical failure because of large pores. It reduces your staff's exposure to monomer, even though the risks are incredibly low based on industrial safety levels. It produces a lesser amount of cement shrinkage during the polymerization reaction. It does not significantly reduce the antibiotic release, but it does reduce the risk of revision as shown in the registry data from Scandinavia. The important thing is once you put it in, you get this first spike of pressurization when you're going in with the gun, and you get another spike when you put in the stem itself. You need high enough pressure to resist the bleeding back pressure of the bone, okay? And you need your cement to have a low enough viscosity still, so not too late in its setting time, so that it can push the cement out. And the aims of your cemented stem technique are to produce a rod inside two tubes, your cement tube and your bony tube. So in summary, what do I think the benefits of cemented stems in total hip arthroplasty? Well, first of all, look at your clinical data from large registry data. The survivorship is better. You can get better positioning because you're putting in everything in a controlled, steady fashion. It will conform with all types of bone shape and bone physiology. The osteoporotic, the stovepipe proximal femur, they will all cope well with cemented stems, as described by the Americans when they say, we can't get a stem that fits this well of an uncemented type. Short term, clinical outcomes from the patients are great. They're patient-recorded outcome measures. So you get the benefits in the short term, but you also get the long-term survivorship. Periprosthetic fractures at the time of surgery are far lower in cemented stems than for uncemented stems. And for myself as a revision surgeon now, I've been a consultant for about 13 years, the joy of revising polished tapered stems where I'm revising the acetabulum. All I need to do is just knock the tapered stem out and put a new one in at the end, and it just makes the revision so much easier with good access to the acetabulum. The only time one needs to remove it is for infections. But of course, the risk is lower in those because we've got antibiotic-loaded bone cement. And then finally, in the UK, cemented implants are significantly cheaper than the uncemented version. So really, the question would be, why would you not use a cemented stem? These are, I think, some very useful further reading references that would be helpful and broad and covering. And that book, The Well-Cemented Total Hip Arthroplasty, is a fantastic book. And I'd like to just say thank you to PAL Academy for some of the slides, and Rob Baber in particular, my friend and colleague there, and my friend Dave Sokart, Professor of Orthopedic Surgery, who's loaned me a couple of his slides. Anyway, thank you very much. I hope that's been useful, and I wish you all the best.
Excellent. Dr. Vikas, you can stop sharing the screen.
I think I have stopped.
And, Nikhil has a very short video, which is 2 minutes, which will, emphasize all the tips and tricks Jason said. So I think we can quickly have a look at it and then have a few words on this.
Yeah, if you have time, I can play it. I can start screen sharing then.
Yes.
Can you see the screen and the video?
Yes, we can.
So I think last week when we spoke about the socket, I had stopped it at this stage where we have just cemented the socket. And that's the local infiltration. Is the video playing?
Yes, it is playing.
Yes.
Okay, good. And you can hear me, right?
Yes.
So that's the local infiltration in the socket. And then now we are starting the stem. So the important step in the stem is that you try and get an entry point that is as lateral as possible. And in hard and sclerotic bone, that does take a little bit of effort. The box chisel, and then that's the trochanteric reamer that creates the lateral entry point where the neck has been cut. Then that's the taper point reamer. It's got a blunt tip, so it doesn't cause any fractures or perforations. And then that's the first broach going in. Generally we start, this is the C stem classic system. So I start with the CDH broach. Now the broach can easily cause a fracture. So what is important is to use the broach like a rasp. You only really use the hammer at the very end. The motion in the beginning is with your hand, and it's used like a rasp with front and back motions. So that's the trial reduction that is on the broach. And then you check for your stability. That's full 90 degrees, adduction, internal rotation, external rotation. You check for impingement, and then that's checking for length. You remember that little mark we made last time? So if you're happy with the lengths, and then you check the shuck test and the coplanar test of Ranawat. Now that's a synthetic cement restrictor, which I've used for this video. But majority of the times I prefer a bone block rather than a block of plastic. Now this is the Palakos cement that is being mixed using their proprietary gun. What is important when you do cemented stems is that you have good and trained staff who know how to mix cement correctly, the correct time. So we have lavaged the femur and dried it completely. That's the cement going in. And you suck the blood that comes out if there is some blood. The thumb is very important because it occludes the canal. Then that's pressurizing the cement. Sustained pressure is important. So you can see that blood and fat coming out under pressure from the rest of the exposed neck, and that signifies that you've got really good pressurization. So cement will really penetrate into the cancellous bone, giving you a nice interface. And this is an additional step that I do. This is something more of tradition. With your thumb, you pressurize it. And then that's the C stem going in. Last time we discussed the difference between a C stem and an AMT stem. This is more boomerang shaped. So you have to have that thumb on the calcar so that the stem doesn't collapse into varus. And you can get very good cementation in your zone 7 as well. Once it is set, that's the no-touch technique. We're using a ceramic head. So I've stopped the video over here. And the rest, you do your reduction.
Okay, thank you. You can stop sharing the video, Nikhil. And before we move on to Dr. Vikas's talk, I would like to make a few comments, and I will then ask my esteemed panel to contribute as well. So obviously in 2020, we cannot ignore cement, and Mr. Jason has shown very clearly that all the registries and all over the world, in all hands, cement does work, and he has emphasized the basic principles and the basic science of cement, I think, which is very, very important. And the modern cementing technique is really crucial to give the longevity which we expect. And really, we don't want to revise once we do a hip replacement. In my practice in the UK, I remember some things, like, for example, one of the consultants used to heat the cement, heat the actual implant in a warm saline bath because he was in a hurry to play golf probably, and to get the curing faster. And I also used the Smith & Nephew Spectron stem, which was a collared stem with proximal roughness and a typical wedge tapered shape. At that time, in the year between 95 and 2000, 2005, the registries showed good performance of the Spectron stem, even though, as we saw in Jason's talk, that the interface here is between the implant and the cement, which is stronger than the cement and the bone. So I would like the other panelists to mention these things, and especially Nikhil and Mahesh to contribute, and of course the other panelists as well. Thank you. So, any words, Mahesh?
I think most of it is really covered nicely by Jason about the type of cement, the quality of cement, the antibiotic usage, and the modern technique of cementing is probably quite well explained nowadays. The only worry as pertaining to our scenario in our country is the environment. And I think people are scared to use a cemented stem in India is because of the changing environment. You keep on operating in variety of operation theaters. The temperature in the operation theater is not well controlled. You are not in control of whether the cement is stored and at what temperature is it stored. The quality of cement insertion gun varies as well. And I think all of these factors have made people wary of using a cemented stem. Although the technique, as I've said earlier as well, is a demanding technique. But if you learn it and use it well, I think you get consistent, long-term, fantastic results. And I never hesitate to use it even in younger patients. But I think in our country, which is probably not true for Western countries, is the environment matters the most. And people don't pay attention. The surgeons don't pay attention to what cement are they using. Are they well versed with the cement, the properties of the cement, the low viscosity cement like Simplex stays runny for a long time and the handling time is much lesser. So then you suddenly struggle when you insert the cement, it's liquid, it's falling all over. And within a couple of minutes, it starts setting. So your stem is hanging up and probably not able to push in. So all of these, I think for Indian scenario, you need to learn the specifics of using cement in the variety of environments that we practice in.
Yeah, excellent points, Mahesh, because unless you do that and unless you actually have hands-on training on sawbones and learn cemented techniques, you will get suboptimal results. Any further points to add, Nikhil, Vikas, Narinder, Surendra?
Just one point about, he mentioned the modern cementing technique, and certainly that is what we do now. What we should not forget is that the 33-year data published by Exeter and the 50-year data published by Wrightington Hospital is not modern cementing. It is actually old-fashioned cementing without even pulse lavage, with thumb pressurization, and even canal occlusion came a bit later. So whilst we don't argue that modern cementing is not good and we would prefer to use modern cementing, we will only really know that it will prove to be better after 33 years or 50 years. But based on the first 15 years of what we are doing, the survivorship is actually getting better. So we think that if you can do a well-proven cemented stem like the Exeter stem or the C stem, and a well-proven cemented socket in the correct way using the correct modern cementing techniques, the belief is that the survivorship will get even better compared to the incredibly good survivorship we already have with cemented hips. So it's important.
Absolutely. I mean, with the advances in materials and bearing surfaces, married to modern techniques, we will do the best for our patients. Any other points, Vikas, Narinder, Surendra?
One point to highlight about choosing what cement we should be using, especially considering the revision in our mind. I think using a pigmented cement is important. Otherwise, we end up a lot of time during revision. All of you are doing revisions, and we end up having poor differentiation between the bone and the cement. A lot of time we end up sacrificing the bone in an attempt to remove the cement. Using a pigmented cement like Palacos would be very really helpful.
That's a good point as well.
I've not noticed that, Narinder. If you keep washing the bone frequently, whether you're taking white colored cement out or green colored cement out, it's not difficult to make the distinction. But the reason you should use Palacos, I think, is because it has the longest and the best data. the fact that it has pigment and chlorophyll is a useful side effect. But if you look at purely data, Palacos does have the longest data.
Of course, data-wise, Palacos is the best, but that's just an additional thing which I want to highlight.
Any thoughts on embolization using the cement gun? It is quite hyped, but I think it's not such a big deal in clinical practice. What are your thoughts, Nikhil, Mahesh?
So I'll let Mahesh go first.
Vikas, Mahesh?
Yeah. Mahesh
Is Mahesh there?
So if you look at the cardiopulmonary effects of cementing, which I was going to discuss in my talk, there are some changes, but with modern anesthesia techniques and good intraoperative monitoring, most of these are negated, and the fear about the cardiac effects are now very, very limited. So gradually everybody is realizing that with modern anesthesia techniques and good intraoperative monitoring, that slight episode of hypotension or the cardiac effect which is seen with cementation is pretty well controlled and does not lead to a lot of adverse events which we earlier were scared of.
I remember seeing a trans-esophageal echocardiograph and a patent foramen ovale patient. And, in those patients, obviously there is a significant risk, but with modern anesthesia, pre-op assessment, you will be careful with choosing the technique for the patients. But it will be interesting to see what Nikhil and Mahesh have to add. Surendra? Any other points, Nikhil?
Yeah.
The incidence is incredibly low.
Yeah.
It has often been used as a weapon by those who support uncemented stems to criticize cemented stems.
Correct.
In the 21 years that I have used cement, at least when I've been operating, I have not yet seen an embolization. There have been 1 or 2 episodes where that has been suspected, but that diagnostically, it's very really difficult to prove that that episode was indeed embolization and was indeed due to cement. And even in autopsy studies, it is difficult to prove that it was cement embolization, that the cause could have been different. If you look at pure evidence, a lot of work has been done in the Australian registry, both for neck of femur fractures and for osteoarthritic hips, using cemented versus uncemented stems. And if anything, the neck of femur fractures where you can use cemented or uncemented, which are the most vulnerable group of patients, even in them, the overall mortality of using cemented stems is less compared to uncemented stems. So I think it's a blown out of proportion.
Yes, I also remember Professor Ross Crawford saying that modern cementing techniques, even in morbid patients, there is no real significant risk. So I think for the audience, there is no real contraindication as such for using cemented systems. You have to warn your anesthetist before you start the pressurization. Some centers use steroids IV at that particular point in time. But again, with proper technique and using proper systems, the risk is not that significant to change our practice or to change the systems which we use. So, Vikas, any more points before you go on to your talk?
Just as a background to my talk, what I feel is looking at our audience and our practices in our country, what we need to highlight is how has it got affected by the market and the results. The main volume of arthroplasty started somewhere in the end of last century, in the late 80s or 90s, to say so, in our country, and it gradually picked up, and last 2 decades have been high volume. But if you look at the implant choices which came in the last 2 decades, why the uncemented practices have prevailed, some points which Mahesh already brought out, that technique was suspicious and maybe technique related failures were an issue in our country, and we have seen failed cemented hips. But also the design which was prevalently used in the late 90s many times were a shape close design, like a Muller design being used for hemiarthroplasties and even for THRs. So shape close had a higher failure issue. Then the quality of poly which was being used with its polywear and its effect. Then the technique. So all these issues together, and then the American influence on our market in the early 2000s. So when the uncemented stems came in and they had to propagate the philosophy uncemented. So all these hit together, and in our market, uncemented is the prevalent theme. I feel if we look around, that a youngster, when he starts, he quickly switches on to the uncemented design. And that has affected the practices, which is now turning around a bit with better designs coming in, the cementing techniques being followed, and the cement availability of cementing guns, the plugs, the vacuum mixing systems now coming in. So things are changing, and things are turning around. But last 2 decades, predominantly in our country, have been uncemented philosophy.
Okay, I think that sets the stage very nicely for your talk, which is on uncemented stem. So you can start your presentation. Yeah.
You can see my presentation.
Yes, we can.
Slideshow. So as we just talked, we need not get bogged down by cemented or uncemented, but there is really it is very difficult to prove one superior to the other. The Cochrane review, which was done in 2010, had most of it was a level 3 and level 4 evidence. And what they showed was that uncemented was slightly faster, which we all have seen. Intracardiac issues or in uncemented were negligible, whereas again 0.18% cemented, which is also quite low. Periprosthetic fractures are significantly higher in uncemented design, and these could be technique related issues. And as Dr. Jason brought out, the failure rate at 13 years being high, and I suspect most of it is coming out of these periprosthetic fractures happening in perioperative or intraoperative period and affecting the longevity of these stems, which could be technique related. Post-op mobility. So in cemented designs, they say that immediate post-op weight bearing is easy and pain-free and is assured, whereas subsidence, fracture rate, or pain, thigh pain, is an issue with uncemented philosophy. Design and handling of these 2 stems are different, totally different. In one case, you are exactly preparing the bone to shape match the implant, whereas in the cemented design, as we just saw, we are creating a receptacle for the cementation, and it may not be shape matched to the stem. It is a force close philosophy, which is different from the shape close, and shape close needs something like uncemented, but a cemented design does not need to match. So the preparation is different. One advantage of cemented, as brought out, was that in infection and in revision settings, you could load it with antibiotics and tackle the situation. So the advice would be not to be dogmatic, and gradually level 1 evidence is coming up, which is showing that both these designs work as effectively, and how we choose one over the other can be anybody's decision. So surgeon needs to decide. Basically how we decide is, in our practice, it is more by and large driven by age. So below 50, most of us are preferring uncemented. Between 50 and 75, it is our choice. And above 75, the literature is definitely showing more perioperative complications, fractures. And so cemented is something to be used above 75. But at the same time, age is not the only criteria. We need to look at the bone quality and the bone morphology, the shape of the metaphysio-diaphyseal canal. So just talking about the uncemented stems, we will just in our talk go through how to choose a stem. Templating we have already discussed, how to check and ensure you have the inventory, the small tips of preparing the femur, ensuring a proper seating of the implant, and finally checking the alignment and limb length. So just to say that all stems are not the same. There are various classifications of these uncemented stems which have come up, but one classification which is very useful in understanding these designs is the Mond's classification. And we'll just look at each design as we go through and their availability in our market. The most prevalent design is the blade stem, popularly called. These are single wedge stems. So they wedge in one plane, They have double taper in the AP plane and the ML. So if you see the lateral view of these stems, they are absolutely flat. So they are bone conserving in that sense, that anteriorly and posteriorly there is cancellous bone which is left. From the top, they have a modern taper, which is usually 12 by 14, which is most of the designs are coming up with it. Few still remain different, like the Accolade, which has a V40 taper. Important thing to note is there is an undercut now in the neck, which allows impingement free movement. So range of movement is more. Taper, each stem has its own type. Even 1214 of one company may be different from the other. So we need to ensure that the head used is always of the same company, because the taper length could differ. Even if the tapering angle is 12 by 14, the length of the taper may be different. So the trials used for the head should be of the same company, and the heads should definitely be of the same company. Then these are proximally coated. So the biointegration is in the proximal, approximately 1/3 or slightly more in some designs. Distally, they are smooth, tapering. They are just essentially for alignment. They do not integrate and they should not get stuck distally. They have these flutes to decrease their rigidity and increase biocompatibility and flexibility of these stems. And some of them have a lateral relief also. So this is a modern taper design, which is most popular one earlier, and which came in first was the Biomet taper lock. And gradually every company has its design in the market. Zimmer has the ML taper, the Stryker has the Accolade, Depew has Trilock, and Smith & Nephew still have to launch their anthology in our country. So these are the modern taper wedge stem, which would be used by most of the youngsters when they start doing their uncemented hips. We'll go to each one's technique a little later. This is a double wedge design, which was before these blade stems came in, and these were tapering in the mediolateral plane also. So if you cut these stems, you see the lateral part is broad and the medial is narrow. So they're tapering from lateral to medial also. So it is called a triple taper stem. These are fit and fill stem. We'll again go in the technique how they differ from these stems. They are again coated proximally. The neck essentially is the same. They have a bullet, distally a bullet filling type of a stem with no integration distally. Some of them are matte finished, but essentially again the integration and fit is in the metaphysis, and they are also called the fit and fill stem because of the size. They also fill the canal. They in our market, most of them have been withdrawn as these wedges have come in the blade stems. Synergy is the only design left, and it is a useful stem in certain situations, which we will see. Summit has been withdrawn. The secure fit has gone. The Stryker has removed it. FMT last few are left and gradually being withdrawn for our country. EcoHip was really not popular. So the only stem left in this double wedge triple taper design is Synergy in the market still, because they have not launched their anthology. The type 3 stem are again taper stems, but they have a metaphysio diaphysial fit. So they are little bulkier stems. The type 1A design is 3A design is called the round taper. They are the Mallory head of the bicontact. Bicontact of Aesculap is still available in our market. They engage the metaphysis and a part of the diaphysis. So it's a metaphysio diaphysial fit. The other design is the Zimmer Wagner cone, which is now come in for even for primary and complex primaries. These are conical fluted titanium stems, which are very flexible. They allow you rotation control, so you could rotate it 360 degrees. So in complex hips where version is an issue, you could use these. They are conical and they wedge into the proximal metaphysis and going slightly into the diaphysis, much smaller than the standard Wagner stem. And then there is the Zweimüller type of rectangular stems. So if you cut them into a section, they are rectangular. They again fill the canal and they are metaphysio diaphysial fit. They really did not pick up in our country and mostly seen in European practice. Type 4 stems are fully coated design, generally limited to use in revisions when we want a diaphysial fit, or sometimes in neck femurs where the bone quality is bad and you want to fill the whole canal. Sorry. So these are fully coated, and two designs which are available in our market are the beaded full coat of Zimmer and the solution stem. They are monoblock, and the preparation of the canal is slightly different, which we can discuss when we go on to the revision talks. And the modular design in these are the SROMs and the Reviton. These are again essentially used in revision of very complex primary hips. And the type 6 stems are anatomical stems. These are newer and still have not entered our market. One design which I have been familiar with during my fellowship is a Fitmore-Zimmer stem. These are right and left. They anatomically fill the complete canal. So they are kind of a filling stem, but coating is proximal. They come as a family of stems, so they are able to restore the anatomy better. So they have, for each size A, B, C, they have different neck length and neck offsets. So the offset changes as per size. So they are more anatomical. For each femur has various options. So these stems are still to enter the market. So coming on to the popularly used, the wedge stem, the preparation of these stems, if you see this cut section, these stems need to hit the medial and lateral cortex. So they are broach only design. They have to fit here in the medial lateral plane. And if you see a lateral view of these stems, they have a 3-point fixation. So they fit, and proximally they are hitting the posterior cortex, then the anterior, and then the posterior. So they get a 3-point contact, and mediolaterally they have to sit cortex to cortex. They are broach only, so distally they do not need to be reamed, since their length is also short and distal profile is narrow. But they need a perfect ML fit. If not achieved, there is a risk of subsidence. And in trying to achieve this, hitting the cortex, there is a risk of periprosthetic fracture. And that's why the periprosthetic fracture rates are 3 to 6% in the per-op period for these stems. You need to be really careful in type A femurs, DOR A and C. C, because of the porosis and a wide canal, you keep oversizing and you can lead to a lot of hoop stresses causing fractures. And in type A, the problem is the distal fit, which we'll see in the next slide, is the distal fit. The other advantage of these stems is all these stems offer you an extended offset option, which last time we discussed. You should check your company guys to give you those. Now, we have just shown here what happens when you don't prepare your femur properly. So if the stem distal profile is not good. So this is an Accolade design. I had the opportunity to study 400 such X-rays during my fellowship, and that time the Accolade design was being reviewed, the Accolade 1. And the problem which we found that in the extremes of sizes, when the bone canal we were using at size 1 or 2 or the 6 and 7, what happened was a distal fit happened before the proximal fit. The good fit is here. It should sit into the cone, not allow any fit here. Some lucency you should see on both sides, showing that the stem, the distal profile has not engaged, and the engagement needs to be in the metaphyseal cone, which if does not happen, and if it hangs out, you will have limb length issues, you will have stress shielding, you will have thigh pain. All these issues can come up if a stem is proud, and hence the Accolade 2 design came up where they decrease the distal profile and also the length. So by decreasing the length, you are avoiding the tightest part of the canal, which is 10 centimeter below the LT, that's the isthmus. So if you are within 100 to 110 millimeter stem, you are avoiding the isthmus, and keeping the distal profile very thin, you could also do that. So this is just an X-ray to show how the fit should be. So here there should be some lucency around. So you see that this is not fitting here. It should not be tight here. Some bone canal should be seen, whereas the fit here should be absolutely into the metaphysis. So the metaphysio-diphysial mismatch should not be an issue in these stems. If that is an issue, then you have the mismatch related complications. Coming to the other design, which Dr. Jason just said was one of the most popular combinations, the Cora Pinnacle. So coral stem has a ZTT philosophy. It is, although the basic stem is a taper wedge, a blade stem, from where the taper wedge stems have come in. The philosophy came in from here. But here the difference is it's a fully HA coated stem, and it has got these undercuts which are Z shaped, and they compress the bone while preparing the bone. So when you prepare with the broaches, the canal, the cancellous bone all around the stem gets compacted even while insertion, and thus preserves healthy bone all around. They do not require to be oversized. So you see, there can be bone left around. You don't need to hit the cortex, which is an issue with the modern tapers. Stem profile, the distal profile remains thin, but at the same time, the full HA coat allows very early integration. So distal integration sometimes is an issue in these stems. However, if it is a wide porotic canal and an osteoporotic male where you don't want to do a cemented stem, sometimes these could be a savior because they are fully coated and integrate very well, very fast, avoiding sinking. So these are some features of taper wedge coral stem which are different from the modern taper wedge. Coming to the triple taper stem, as we discussed, from mediolateral they taper. The shoulder is broad. Here you see they are fill and fit. So fit is there, but at the same time, fill is also giving some stability. So they need not hit very hard the cortices, because some stability comes by inherent filling of the metaphysis. So metaphysial fill also provides the primary stability and allows integration. However, they lead to a lot of bone loss. So you have to broach the complete shoulder. Very less cancellous bone is left all around. They are ream and broach philosophy. So you got to ream the canal. So there are some advantages of it. When you ream, you are able to tackle a tight distal fit canal. So even a door A femur can be tackled with a ream broach system, which is not always possible with only broach system. So many of us advise that if you are going in for a only broach system, that is the top taper wedge stem, and you feel the distal canal is tight, you still may need to use the reamer. So you should not throw away your reamers totally, and either a flexible reamer or a rigid reamers you should have even while using taper wedge stem to avoid the distal fit problem, and which is tackled by this triple taper stem. They have low risk of subsidence as they fill the canal primarily well, low risk of fracture because you need not oversize, and you are able to prepare the canal by the ream broach. So all types of canals could be tackled. So if somebody who's not very confident in properly templating or using a blade stem, a triple taper stem is a useful stem to have in your armamentarium. Unfortunately, the only stem left in our market right now is a synergy stem. So you see here, you have not filled the canal, but they are stable. They allow some bone around, and they tend to fill the canal by their shape. Just a word about the short stems. So when they initially came in, the idea was you make them short, so short that you could conserve the bone. Mont also gave a classification of these stems, and they were like a mid-head resection BMHR stem, or a comma tape stem like a banana stem, which was calcar loading stems. Then they came up with calcar loading stem, like this one is a calcar loading stem with a lateral flare. So they need to load the lateral cortex. This is a Metha stem, a successful design. Zimmer Mayo, again, you load the calcar and hit the lateral cortex. So with a lateral flare. So these are type 3 stems of the short stems. And then you have the standard design, but shorter in length. So you have Accolade 2, you have Trilock bone preserving stems, you have taper lock microplasty. What they have essentially done here is kept the stem, made it short, given them a lateral relief, and a slight change in the shape to negotiate the shoulder of the canal well. So you don't have to do a lot of bone removal here. So they are bone conserving more than the traditional stems. They avoid the mismatch by being short and very thin distally. So thigh pain is less because they make the distal profile flexible. And they say there is ease of revision, but if you actually go to revise them, you almost lose a similar amount of bone. So that may not be true always. However, if you use the designs without the lateral flare, like the banana stem or the BMHR, then there is a steep learning curve, there is risk of malalignment, and there is limited long-term data on that. The only short stems which have some data is the Metha and the Mayo, and the Nanos, the Pegasus. These are hardly being used. And now the Accolade 2 and the Trilock designs, which are the short stems, but not the traditional ones without a stem, which are which are in the market and are being used now. So like I'll just, these are two of my cases only. When this is a SMF stem. So this is a metaphyseal stem which was used by Smith and Nephew, which they now, I don't know whether they have it or not. Look here, this is a traditional way which is wrong here, that they need to sit laterally. So traditionally, if you see the X-ray, this looks right and this is wrong, but they are calcar loading stem and they need to hit the lateral cortex and they need to load the calcar. So there are learning related issues here. And so most of us have stopped using these stems, have gone back to, and this is what we are usually using stems like Accolade 2. This is a Trilock bone preserving. Even an Accolade 2 looks something like that, or a ML taper. So these are the more popular designs now. And the real short ones are gradually not being used by us. Again, that issue of lateral loading, if laterally it doesn't touch the cortex, then there is a chance that these stems will subside. So short stems have a learning curve and may not be always so successful. Templating, we have, so once you have decided what stem to use, you should template them and decide what will be your neck cut. This all we have discussed in our previous talk, but just to go through that you decide your neck cut, then you see whether the design of your stem is matching the canal or not, and whether you are able to restore offset or not, and what will it take to restore the offset, what angle of the stem or what offset. Again, few images how in all complex cases you need to template to be reproducible. Now coming to the preparation. So if we talk about preparing the proximal femur, it is drastically different if it is an anterior approach or posterior approach. So we need to know what approach we are familiar with and what we are going to do, because the femur looks different anteriorly and posteriorly. If you see the femur anteriorly, you see the intertrochanteric ridge well, you hardly see the lesser trochanter. You can see this saddle of GT well. So your landmarks change. The LT is no longer your prominent landmark. Your measurements may be from the tip of the GT or the intertrochanteric ridge. So these things you need to keep in mind and expose, whether it is an anterior or posterior approach, expose your neck well. And the popular approaches are mainly posterior and the anterolateral. The direct anterior ones are a little more difficult and need even sometimes a specialized table to expose the proximal femur. What we need to understand is whatever approach we are using, we should know what are the landmarks clearly visualized in these approaches. Position your limb in neutral when you are marking your cuts. So you can use a resection guide if you want. The neck shaft angle can be determined by the guide, and determine the length of the cut which you had templated. The cut also needs to be determined by the offsets. So if you do not have an high offset stem and you have offset which is really high, you may have to cut the neck deep, and then you may use a longer neck or a plus size head. So that will sink the stem and still allow you by a plus head to give you a higher medial offset. Whereas if it is a valgus, you need to keep the neck cut slightly higher, and then you may use a minus head and the stem could be slightly proud. So you should know how you will play around with your neck cut, expose it well, mark your cuts. Usually the piriform fossa is the starting point, and there is what the cut starts from. And the angle is determined by these templates, which are usually provided by the company. The canal opening, now with these modern stems, the lateral entry, which earlier used to be an issue that you need to gouge and remove a lot of bone from the trochanter, like this is a Zoemuller stem or even a CLS stem for that matter, you need to remove this bone. In these stems, it is good to expose the GT well and maybe take a sliver of bone, but you need not overdo it because there is relief given for the entry. However, removing some amount of bone and ensuring that you are entering through the lateral most part of the saddle gives you a straight shot at the canal and avoids the varus of the stem. So this is something which you need to know about your stem, whether it has a lateral relief or not, how much you need to go into the trochanter, where is the canal entry. So canal opening is important. And if, as we said, that if the canal is tight and if there is a risk of distal fit, you may even ream the canal using a rigid or a flexible reamer, even if it is a only broach system. Lateralization is important. So we, as discussed, we need to lateralize. When you start broaching the canal, you need to make sure that your broach enters parallel to the posterior cortex. This entails that you are following the anteversion while preparing. Although as you approach the size match of the canal in the uncemented systems, as we discussed, the stem would take its own version. But to start properly is important. Otherwise, you may hit the cortex and cause periprosthetic fractures. So it is more important to insert it well and match the shape initially to avoid a per-op fracture. The broaching needs to be rhythmic. So by rhythmic, some people even take out musical notes while broaching their femur. It should be very gentle. Almost 70 to 80% of the broach should go by hand in while preparing. Advancement should be in millimeters and controlled. If you are getting stuck, you could reverse it for a few millimeters and again broach it. Allow some time for creep and make sure that it is a very gentle uh, procedure. It is not slam bang and you'll end up with a fracture. You monitor the tactile feel and as well as the auditory feel. So you can hit the cortex and get that difference in sound. So that difference in sound you should be able to pick up while you get trained on these stems. So end point, where is the templating going to end? Sorry, the preparation going to end depends on on the templated size, then the broaching sound and your fit and your toggle. So if you are able to toggle the uh, uh, broach or not. So there should be no toggle in the canal. Femoral preparation also involves planning your offsets. So as we discussed, if it's a high offset femur and you don't have a high offset stem, you need to adjust your neck cuts. You need to sink the stem, use plus heads. And if there is a higher offset stem available in your trials, you should decide that I may need to go in for a higher offset stem. So it needs to be available for your surgery. So there are various ways to check the limb length. These are few things at the end, at the time of trial reduction, which you need to check. The limb length can be done by various techniques. Some people use pins over the crest or on the cotyloid fossa, and then from that pin and a mark on the GT before dislocating the hip, and after your surgery you can reduce and check how you are. So limb length, you should have your own technique. Some people just use the knee and heel test, where so all 2-3 things you should use to see whether your limb length is restored properly or not. After the length comes the version, which the coplanar test we described last time. So coplanar test should be done. For the laxity, you should do the shuck test. The no business position, which is complete internal rotation and adduction, in which if the hip remains stable, it is highly unlikely that it will dislocate. Another important thing, two important things are the external rotation. So you should be in extension, you should try and externally rotate and see the impingement anteriorly of the capsule. If the capsule is tight, if there is an impingement anteriorly, you may have to release or even excise the anterior capsule sometimes if there is impingement and the external rotation is tight, because then the posterior dislocation risks are high. Impingement all around the neck should be physically checked. The host to host impingement and the host to implant impingement all needs to be checked before you plan to close the hip. So what are the pearls in an uncemented stem? You need to choose the stem as per anatomy. Unfortunately, as compared to the cemented stem, where you could prepare the bone for the stem and you could be universally same when you're preparing the bone. But here it should be as per the design you're using. So handling of that stem should be known to you. In broaching, another thing which I wanted to point out is the coating also affects. So you should know when you broach your stem and prepare your canal, the actual implant has a coating and a millimeter or so of it may not allow you to sink in well. So every stem has a different coat. Like a Trilock here is very ultra porous coat. It has a gription coat, and to enter this, sometimes you have to over broach the canal a millimeter or two. So these things individually about the each design you should know when you are handling these stems. So uncemented stems need more precise handling and knowledge of the geometry, design, and the coating so that you prepare to match the stems. This templating is also important. You simulate the surgery when you template. You prepare the femur meticulously to match the design. You trial a number of times before you open the final head. Once you have put in your stem, or even before stem when you're trialing to decide your offsets. So deciding your offset, whether to use a high-end standard, you should trial well. And then after putting the stem in, what should be your head size? So you get 2 shots at it to decide your offsets, which should be carefully done. Ensure that you have seated well, and finally check the balance as we just mentioned. So these are few references which the audience can go through about the implant designs for cementless hips. Thank you. So should I stop sharing?
Kiran, you need to get unmuted.
Kiran, you have to unmute yourself.
Okay. Yeah. Thank you very much, Vikas. That was an excellent talk, which gives a lot of clues and tips to make a reproducible technique. When you choose uncemented stem. There are a few points I'd like to make, and the rest of the panel can chip in. I would like to thank Mahesh Kulkarni. He has to leave for another commitment, and to thank Mr. Jason. Like both the talks emphasized technique dependent. Okay. Now, my take is that the cemented system, even though is technique dependent, is still more forgiving than the uncemented system. Because like Mahesh said, if you are aware of all the factors like the theater temperature, your cement characteristics, you can still play around till the last moment when you are inserting the cemented stem. And in the uncemented stem, there is no room for error, because once you prepare the channel using the broach, the path is already made and you're committed to the path and you cannot change it in the last minute. So I think both are technique dependent, but the cemented system is still very forgiving and you can still adjust till the very last moment. The short stems, I think, should be just for theory. You should not consider it. The most infamous short stem is the Proxima stem, which Mahesh Kulkarni will definitely smile about, and when we talk about it. But certainly that is not to be considered in our modern practice. There are results out now for the Korai, which is now coming up to 30 years, and again, if you do it well, it will last well. One final word about the length of the stem. Dr. Nikhil Shah mentioned about the boomerang-shaped C stem, which is smaller, and the Exeter is a longer stem. And I remember a story which was told to me when I was at the Exeter conference by the faculty there, that when Professor Ling designed this, he had a napkin in the hotel where they're sitting and talking about it, and the napkin length was a particular length, and when he drew the sketch of the Exeter, it was defined by the length of the napkin, and when the engineers made it, that's how the Exeter was a longer stem. So I will stop my thoughts here, and I would like to welcome Mahesh. He has to go somewhere, and then the rest of the panel. Thank you very much.
Thanks, Kiran. I think you've already summarized most of the things. Again, I personally believe that after starting my practice, being trained in the UK, which is mainly uses the cemented stem very successfully, my initial thought process was to try and use cemented stem as much as possible. But I gather the support that we have here, and as I've mentioned about the environmental factors, have slowly made me use the uncemented stem in 90 to 95% of my primaries, which is probably true for most of us. And I think a little bit of laziness creeps in as well, that you want to get out of the theater by doing a decent job. And if you're experienced enough, you might prevent the complications of using an uncemented stem. But I think I agree completely with you that a cemented stem is probably more forgiving, has given excellent results and is much more cost effective as compared to uncemented stems. But I think it's fashion, it's the American influence on the practice in India, and it's the marketing, and it's also time saving for people who want to get through big lists.
Thanks, Mahesh, for joining and for your comments and for getting Jason to talk with us. Thank you.
Thank you very much. Thanks a lot,
Thanks,
guys.
Mahesh.
Yeah.
Thank you, Mahesh.
Surendra, you have some words. Nikhil.
No, I think Kiran, you have covered everything really. I have nothing to add. You know that my opinion is highly biased, so I find it very difficult to give an unbalanced opinion. I'm a big fan of cemented hips. I think 100% of my practice is cemented primaries. We have 50 years in-house data. So when anyone comes to me with a new stem or a new design and tells me this is the best thing, I just tell him, come back after 50 years. What else can I say?
Yeah, I mean,
So
Nikhil,
I find that
absolutely.
No,
very, very difficult to.
You
There's
know,
no
you
point in even
mentioned,
discussing as far as I am concerned. I'm so
I know,
biased.
I know. I mean,
So
I don't blame you because you are in a system, you have the data, and yes, you are right. And probably I would have done the same thing if I was in your position. But you mentioned an important point that the registries didn't look at the modern cementing techniques. And in fact, there's a paper out there about the French paradox, where not good-looking cementing and still those stems performed for a long time. So I think that the materials and the tribology have improved, but with even older cementing techniques, the outcome and the longevity is fairly substantial for the cemented systems.
yeah, I think if I have to give you a fair view, the Australian registry does have very good results with an uncemented stem. And increasingly, what I have come to realize is that you should use one or two of the best performing cemented stems or the best performing uncemented stems. You should do lots and lots and lots of those two designs. It is better to do hundreds and hundreds of one or two designs of stems rather than two or three of 100 different designs of stems.
Agree.
And the third point is learn to do it properly and do it frequently. If you can do that, whether you use a cemented stem or whether you use a well-proven uncemented stem, you should really be able to get in excess of 95% survivorship of your stem at 10 years. The second point is we discuss too much of stems when we discuss cement versus no cement. The survivorship is not the stem. The survivorship is the hip. And this is something that sometimes, when I meet my friends from Exeter and, we are at Wrightington and we are all good friends and we have a bit of a light banter about how they only talk about their stem, but they never ever discuss their hip or their socket. Whereas data should really be the whole hip. And when you bring the socket into the picture, it is quite clear that what matters is the bearing and the wear of the plastic. So really, what is going to determine long-term survivorship of the hips in the future is any device that can be fixed to the bone correctly, but a bearing like ceramic on polyethylene, on highly cross-linked polyethylene, or metal on highly cross-linked polyethylene, that will reduce the wear. I think the argument should be about the bearing, not just the fixation.
Yes, and that will bring us nicely to the next webinar where we will talk about these things. Any other points which are not covered, or any other things which need further discussion? Vikas, Narinder?
Yeah, most of the points have been
From Vikas
discussed.
regarding what coating do you prefer? You spoke about uncemented stems, but all of them come in different kind of coatings, ranging from
So
hydroxyapatite, and why do you prefer that?
So there is no particular preference for a coating. That basically all the modern taper wedge have selected their own coats because most of them are patent in their hands. So like Gription coat has been selected by Depew. It's an ultra porous coat. The stick tight coat is the Smith and Nephew. So they have their own coatings. Most of them, most of the modern coatings allow a 3D integration and a bone ingrowth. So most of the coatings are good. When you choose a stem, it is more by the design as of now. The proximal coat, the HA is almost now going down. Even the Corel, the problem with Corel is the HA coat and distal integration, which although is not significant problem, but that is the reason why the neo design Trilock came in. So proximal coating is something.
Corel is the highest surviving.
Yeah. Yes. So today we are talking of, that was one point which I want to cover. Dr. Nikhil and everybody keeps now talking about 30 year and 50 year and number of hips which have survived 30 and 50. But we are now implanting hips at 20 years on patients who are going to live 90 years. So we also need to look at the advantage of biointegration. So it is not totally ruled out that a hip may not live for 60, 70 years. So we really don't know the answer whether the acrylic would give us that much time. Yes, it is giving us 30 and 50 in some cases. And there is known cases and known follow-ups. The problem with modern uncemented has come, these designs have come later than them. So the coating, the design, everything has evolved in last 20 years. So the race is not the same. The duration which we are looking at may change. What we call long today may be midterm. So these are the issues which still we need to think of, whether we should give away the biointegration part and stick to acrylic, or we should think about ingrowth and forget it stem, like you put in it ingrew. The most of the failures still of the uncemented design are technique related. They are not the integration failures. Integration failures are fewer. And as Nikhil pointed out, both of the stems are doing well when we talk about 20 and 25 years as of now. But when it comes to 50 and 60 years, we don't know whether it is required or not to think of that long. And if we have to, then whether this will surpass the cemented philosophy. We don't know.
And just one question to all the panelists, actually, both the cemented and uncemented side of the story. In a DOT type 1 canal, which stem should we be using, and any there are issues for both the cemented and uncemented. So which one we should be preferring? This is more for the audience, because we have our own personal bias, but what should be the science behind it?
So DOR A, the problem is tight distal fit and a poor cement mantle if not prepared properly. So DOR A is less forgiving even for a cemented stem, and maybe reaming and broaching them to suit a uncemented stem like a triple taper design may be better than doing a cemented where you may not get a proper mantle. Otherwise, you need to ream and broach properly and get your cement mantle well. And as Nikhil would always say that A, B or C, it will work. But
yeah, my answer will probably make you smile.
No, but
so I'll tell you the honest answer. I met Dr. Larry Dorr in 2014 when I traveled to America as the Hip Society Fellow. And I had done cemented hip replacements for 15 years before I met Dr. Dorr. He was a wonderful man, very knowledgeable. And for the first time in my life in 2014, I learned that there was a Dorr classification of the femur. And so I realized that for 15 years, I was putting in a C stem and an exeter stem in everyone from 17 to 105 without even knowing that there are meant to be a DOR A and a DOR B. So when I came back, I looked at all the follow-ups and all the hips that you accumulate over 15 years. That's a lot of cases. And we follow up everyone forever. So I made sure that my arthroplasty practitioner who follows up my cases, always, I taught him what a DOR A femur is, and he was meant to take x-rays of that when they come for follow-up and show it to me. And we did it across the board. And I realized that I've been putting in cemented steps in so-called DOR A femurs for 15 years. So far, there has not been any problem. But if I see any problems in the next 5 years, I'll let you know. So for me, it doesn't matter. The classification becomes irrelevant for me.
So Dr. Nikhil, will you choose a zero stem or in an A femur to undersize your stem and use that petite stem?
So that's what, when I template my hips, I don't think of an A femur or a B femur. I just think of the femur.
So you just ensure that the mantle is there.
The mantle is a flawed concept. People believe that the mantle is the thickness of the cement. My understanding is the mantle is the strength of the interface. There was a beautiful paper that was written from Stanmore that unfortunately got missed by the people who read literature. They looked at and compared thin mantles and thick mantles, and they defined thin mantles as 2 millimeters or 3 millimeters and thick mantles as more than that. And they showed that there was a slightly improved survivorship with actually thin mantles. And so the argument was, is the thickness of the mantle that matters, or how good your cement integrates into the cancellous bone? So if the femoral canal is narrow and you have to use a slightly smaller stem size, but if you can get good integration, it makes no difference. And Kiran mentioned the French paradox. Again, what the French paradox is an incomplete mantle. What the French did is they took the Charnley stem, they modified it, and they called it the Charnley Kerboul stem. And that stem was a composite beam philosophy. So you take the largest possible stem and you stuff it into the femur so that the stem on its own is very, very stable. And the cement then just works to fill up the spaces. So by definition, the mantle is incomplete, but the survivorship was excellent.
Like the hybrid stem.
Yeah.
So,
Well, just one question in this. So distally, if you feel that the canal is tight and when you're broaching and you're preparing, don't you lose the, or reaming, don't you lose the cancellous bone distally in a very tight canal? And
I've not, only once or twice I've had to use the 7 or the 8 millimeter taper pin reamer to open up the canal. But usually, if you know, the tightest part of the canal is at the level of the isthmus. So that becomes a problem when your stem is long. If you're so the Exeter stems are 156 millimeters or 150 millimeters long, 156 6 inches. You know, that's like your 6-inch scale. Whereas the C stem is I think the smallest one is 112 millimeters, and the biggest one is 139 or 140 millimeters. So most of the times my stem will stop short before I even reach that part of the isthmus that you have to open up with your reamer. And for me, that's a big advantage of the C stem, because the length is small.
Exeter now has 107. So Exeter now has
but
107.
They use their short stems for in cement revisions.
In cement revisions,
not as a primary. Whereas the C stem as a primary stem is a shorter length stem. But like I said last time, the C stem is slightly more demanding to put because it is boomerang shaped, and if you're not trained, it is more easy to get it into varus. So you really have to be careful when you insert the C stem in to try and avoid that varus. Your zone 7 cementation is extremely important. Whereas in Exeter stem, it is very difficult to get it wrong. Even a relatively inexperienced person, he can put an Exeter stem in. It will probably give you 20-25 years. So if you want to start with cement for the first time, I would start with an Exeter stem, because it is nearly impossible to get it wrong. You can get everything wrong, but it is very difficult to get an Exeter wrong.
Yeah, there is a paper about that where they looked at the Exeter survival, where the surgeons were, all across the spectrum, not only experienced consultants, but they looked at, registrars and trainee registrars doing it. And as you said, the philosophy of Exeter and the way it is forgiving, it actually did well across the spectrum of talent doing it. I mean, just a few tips before we close this webinar is like when you do the canal finding, everyone emphasized the importance of lateralization and the posterolateral corner and having small gouges and nibblers, just to pay attention to that so that you go down the fairway. And sometimes, when you use a canal finder, what I tend to do is use that, and as I come out, remove that rim, that sclerotic rim, so that doesn't, dictate a varus placement of my stem. And these few things, I mean, these things are very important to get the fairway. Otherwise, it will affect if you're using cemented stems, it will affect the cement mantle. And I agree with Nikhil that we should not be too focused on the thickness of the mantle, because that is really impossible to get it. But what we must focus on is the preparation, getting the interdigitation between the cement and the bone. And if it is a thin mantle but good interdigitation, then that will be an excellent hip which will last for a longer time. But if you have a thick mantle and no interdigitation between the cement and the bone, then that hip won't do well. And one last word about cemented hips. I remember one of my professors in UK doing a hip replacement, and while talking, and explaining to the juniors, when the time came to insert the implant, he inserted the implant the other way around. And all of us were, aghast looking at it, what's going on. And then we said, hey, prof, look what you've done. You have put the implant the other way around. And by that time, the time was going on, and he just did it, knocked it out, freshened it up, and then turned it around and put it back in with a fresh packet of cement. So you can get away with cemented hips, even if disasters happen at the last moment. But with the uncemented one, you cannot. So I think both are technique dependent, but the more forgiving is the cemented one. And in my practice, I tend to favor the cemented implants. But as Vikas said, you have to really look at you cannot put the baby out of the bath water. You have to look at all the things. And certainly we are doing it in younger patients, and we have to keep our minds open to the uncemented implants as well. So I think that about sums it up. Unless there are any more words from the existing panel, we can close this webinar. Surendra?
Yeah, it's well summarized. I think it's a judicial balance between selecting the implant is very much important. Both of the philosophies they stand right at their places. It's more of a technique dependent. So probably I'm more of an uncemented person, but after listening this webinar also, I had bit now more got tilted towards the cemented side. So definitely it's a well discussed seminar which we had today.
Nikhil and Kiran behind the cement. It is.
So with that, I think I'll take Ashok's permission, and I will end this webinar with special thanks to Jason Webb, Mahesh, Nikhil, Vikas, Narinder, Surendra.
Thank you.
And
Thank
all
you.
those.
Thank you.
Thanks a lot.
Thank you. Bye. Bye, Nikhil.
Thank you, Nikhil. Thank you.
Thank you.
Vikas.
Narinder.
See you then.
Bye, Surendra.
See you. Thank you, Narendra.
Bye.